and I would like to take you through the following: antimicrobial resistance, global challenge, dynamics, impact, principles of antibiotic prescribing, how we decide about the duration of therapy. I would start with this slide from a person known as Ramanan Lakshminarayan. His name is not come. It was an editorial published in 2013 in Lancet Infectious Diseases. So it says, antibiotics paved the way for unprecedented medical and societal developments, and today indispensable in all health systems. Can you think of any one situation in which we don't give antibiotics? Whether it's a delivery, a simple thing like a cesarean, or a baby who's in the neonatal ICU, or an elderly person who goes for a cardiac catheterization, antibiotics are prescribed everywhere. A surgeon puts a knife to a patient half an hour before he gives an antibiotic, and he hopes that one more dose goes at least 6 hours later, even if it's something as simple as a hernia repair. So you cannot even think of any medical procedure which is done without antibiotics. A person with a congenital heart disease goes for a simple thing like an endoscopy, even he is going to get a prophylactic antibiotic. But the way antimicrobial resistance is progressing, within just a few years we may be faced with dire setbacks medically, socially and economically unless real and unprecedented global coordinated actions are immediately taken. Think of the days of Lister. What used to happen? Babies would be born, mothers would die of sepsis. Why? Because the microbes would take over the mother. So we would be going back there if you and I do not stand up today and take up some action. It is similar to what is happening with climate change. What we do today affects our future generations. So we have to act as responsible global citizens, not just our country. This is from a report in 2014 by an economist. He was asked by UK government to come out with a report on antimicrobial resistance. And he says that in 2050, this would be the #1 killer. More than cancer, cholera, diabetes, diarrheal diseases, measles, road traffic accidents, and tetanus. So, perhaps 2050, we would be going back to the pre-antibiotic era when you would be trying to kill antibiotics. So, we do not want that to happen, and we need to stand up and take action. And at the same time, the antibiotic pipeline is going down. Pharma companies don't want to make antibiotics. They spend 10 years research, they get an antibiotic, and in 5 years, resistance is there, so people stop using it. Why would they do it? They would rather invest on an anti-hypertensive or anti-diabetic or something which will go on for maybe 50 years. Someone starts taking anti-diabetic medications, he goes on for the rest of his life. So that is the way the pharma company looks at it. So we are not going to get too many newer antibiotics. With that background, seeing that we have a grim situation, let us look at what we can do directly when we prescribe antibiotics. How else to tackle resistance will come up later in the course of the day. So the principles of appropriate antibiotic prescribing. So those are the broad principles. Treat bacterial infection only. Optimize diagnosis. So don't think that what the microbiologist comes around saying is not to be given any importance. Unless you can diagnose something properly, you cannot treat it. Maximize your treatment so that you eradicate the bacteria. Don't allow them to linger on. Don't underdose. Don't give shorter durations. Recognize local resistance and prevalence. Utilize pharmacokinetics And it's not that pharmacology is only a subject to be studied in third year MBBS and full stop, close the doors on it. Integrate local resistance, efficacy, cost, and effectiveness. So when we put everything together, what we get is we are prescribing antibiotics appropriately. So just a simple case. I'm a pediatrician basically to start with. So I come up with a pediatric case, a 1-year-old baby, fever, cold, respiratory distress, and no similar illness in 2 other family members. That gives you a clue that something is common there. Received oral augmentin, very common. Is having 70 respiratory rate, prolonged expiration. I think any pediatrician sitting in the audience will tell you this is a clear case of bronchiolitis. Was given nasal CPAP, IV antibiotics, Ampigenta, and IV fluids nebulization. That is his chest X-ray showing some hyperinflation, and this is vastly normal. CRP is 14 with a normal value of less than 10. On the same night, the child became more sick. Antibiotics were upgraded. But what did we find? The nasopharyngeal aspirate was positive for influenza virus. We know that most bronchiolitis is because of a virus, right? So all infections do not need antibiotics because all infections are not bacterial. Respiratory tract infections are most commonly treated acute problems in primary care. Misuse of antibiotics is rampant. Majority are viral. The other common condition is diarrhea. Poor child comes with diarrhea and all he gets is an antibiotic, whereas he should be getting ORS or something like that. Antibiotics neither shorten the length of illness nor prevent development of pneumonia. Unnecessary treatment puts these children at high risk of resistant bugs. So when we treat, we should try to treat only bacterial infections. Now, this case also tells us the importance Sorry. So if you did not have this, then perhaps you would have continued with these higher antibiotics and God knows what else would have been done. So here we see the importance of a proper diagnosis. So don't think that we can get away with giving antibiotics without a proper microbiology lab support. Now most people who would be doing only OPD practice would say, हम तो blood culture नहीं कराते हैं, हम तो nasopharyngeal aspirate नहीं कराते हैं. Maybe the time has come to think differently that we cannot continue doing that if we want to be more responsible in our prescription. So we need to also, patients, parents will come and pressurize you to prescribe something more than just your, churan chutney. You try to get away by giving Phenargan, you try to get away by giving paracetamol or maybe some cetirizine. They will pressurize you to prescribe an antibiotic because now we have a population sometimes who are more educated. But we should learn to resist that temptation to prescribe unless you have some diagnostic clue that there is something more than just a viral infection. Again, another case, 6-month-old baby, cough, fever, respiratory distress. See, it is similar. But here the child was toxic, minimal retractions, right-sided subclavicular crepitations, bronchial breathing. You made a diagnosis of community-acquired pneumonia. The chest X-ray supported your diagnosis. And here the child was prescribed intravenous antibiotics, the same antibiotics, but here the child started improving by 24 hours. So, we need to choose our weapons depending on the target, rules of rights, the right bug, the right dose, the right time, and the right route. Choice will be determined by the site of infection, the organisms that are possible, penetrability of your antibiotic, the mechanism of action, toxicity, and so on and so forth. So every time you prescribe an antibiotic or an antimicrobial, ensure it is the right patient, the right drug, the right dose and room, the right duration, and do not forget the fifth D, that is de-escalation. This is more true when you are dealing with critically ill patients where you think time is absolutely vital. You cannot delay your antibiotic till you get a diagnosis. So you start the patient on a drug, you choose the highest possible dose, you choose an intravenous route, but on the third day or the fourth day, when you have more, proof whether you did the right thing or the wrong thing, you should start thinking whether you need to now step down or step back. So this is something that Shakti fished out a lot of material from WHO. So this is the severe, make an informed choice. This is based on the severity. A patient who walks into the OPD and is otherwise walking, talking, you don't need to be so aggressive as compared to a patient who is already, say, immunosuppressed in your ICU, on a ventilator, with shock, with high-grade fever. What is known as risk stratification. So we always need to risk stratify. A patient who's in the OPD is completely different from a patient who's hospitalized and in the ward, and is completely different from a patient who's got multi-organ failure and is sitting in your ICU. The source, what is your drug-resistant pattern, what are the patient factors, and what are the cultures, right? So based on this, we make an informed choice. Now, another important thing is 40-year-old 40-year-old male, community-acquired pneumonia, in the ICU for 5 days, currently improving, afebrile, ventilator requirements are down. Somebody sent an ET aspirate on day 4, and what did you find? Without fail, you find Acinetobacter baumannii, sensitive only to colistin, and somebody wanted to change the antibiotics to colistin. But is that right? Perhaps not. Treat infection, not colonization. We know that any device in the ICU, catheter, endotracheal tube, intercostal tube tray, will be colonized, and if you pick up an organism from that device, it may not reflect the true infection. If the patient is improving, asymptomatic, you do not need to treat that patient. So, the principles of an optimization, how do you optimize your antibiotics? Here I said accurate diagnosis is a must. Successful chemotherapy must be rational, and rational treatment demands a diagnosis. This may be provisional, it may later be proved wrong, but the treatment chosen should be based on some explicit assumption as to the nature of the disease process. I hope all of us remember this principle when we are writing an antimicrobial. And accurate clinical diagnosis is key to limit antibiotic prescribing. Sounds funny, no? You need a diagnosis, only then you can be confidently stopping your antibiotics or not giving an antibiotic. So remember, say for example, we look at this slide later, scrub typhus, Kawasaki disease, systemic onset GIA, again all examples mostly from pediatrics. All of them will look like sepsis. Also, macrophage activation syndrome. No? Platelets are dropping, the TLC is dropping. So all these you should learn to recognize and suspect and prove. Only then you can limit your antibiotics. Don't forget complications or disease progression. For example, a patient with pneumonia ends up with empyema, meningitis, subdural abscess, UTI, pyelonephritis, staph sepsis, deep-seated abscess. If you have a patient with pyomyositis, until and unless the pus from within the muscle is drained out, your antibiotics will do nothing. A patient with pancreatitis, he has a collection, you need to drain it. So until collections of pus are drained, all your antibiotics are going to be useless. So use appropriate imaging modality. See this patient, you can suspect an empyema, and if you do an ultrasound, you can see that a thick septate, and you can probably end up treating this patient better by draining this pus. Also, do not forget, as I said, macrophage activation syndrome, especially in tropical infections like dengue, scrub typhus, all of them would have this complication, and platelets will start dropping, TNC will start dropping, and you will find the patient is spiking. High grade fever is again looking very toxic. So if you do a bone marrow at this stage and do some other tests, you may prove that, and you may actually need to give immunosuppressive therapy rather than giving higher antibiotics. How can you maximize your therapy? By giving the maximum possible dose that is not going to be toxic to the patient. So why do we need that? Until you eradicate bacteria, if you eradicate, then only you will maximize clinical cure and minimize the potential for resistance. If you give inappropriate treatment, fail bacterial eradication, there is selection of resistant bacteria which will then spread. So this was recognized as early as 1945. Fleming, the person who discovered our first antibiotic, penicillin, when he was accepting his Nobel Prize, the speech that he gave, in that he has mentioned, it is not difficult to make microbes resistant to penicillin in the lab by exposing them to concentrations not sufficient to kill them. The same thing has occasionally happened in the body, and by exposing them to non-lethal quantities of the drug, making them resistant. We doctors are very, very cool about it. We say, the patient is non-compliant. Why is he non-compliant? Because we have not explained to him the importance of completing the therapy. So what happens? Patient takes the drug for 2 days, he feels better, he stops it and he thinks, अच्छा है रख लेंगे अगले बार डॉक्टर के पास जाके फीस नहीं देना पड़ेगा हम इसी को खा लेंगे. But this is what actually promotes resistance. This is what is happening in anti-tubercular therapy also, that the course is not completed, they become resistant and they have resistant tuberculosis. So it is very important that we need to completely eradicate the bacteria. Of course, this is now ending up in your problems, but that is something totally different. The other thing, especially in patients who are very sick, is early therapy. This is the fraction of patients who survive, and this is the fraction of effective antimicrobial initiation, how late it was started. So each hour of delay of initial effective antibiotics increased mortality by 7.6%. So if you give suboptimal antibiotics and give it late, you end up with a high mortality. This is the reverse. You end up with a high survival if you give effective antimicrobial initiation early. So there are two things actually this graph shows. One is early and one is use of effective antibiotics. So that is why it says when you start with a broad spectrum of antibiotics. But you should also know that when you do this, you need to send cultures, you need to do something to keep a diagnosis, and with that you need to pull back your antibiotics after 2 to 3 days. Principles of appropriate antibiotic procedure: recognize local resistance patterns. So we need to know our local antibiograms. For example, anybody who comes with a pus collection in which you suspect staph, we all end up giving vancomycin. But we never think that the serious staph infections in India, even today coming out in the community, 80 to 85% of them will be methicillin sensitive Staph aureus. And when you give drugs like cloxacillin or cefazolin, you're actually having better penetration of the drug. They are more cidal rather than vancomycin. So serious infections with staph are due to MSSA. Penicillin resistant strep pneumonia is not so common in our country. What we are always battling with is the resistant gram negatives. It's the Klebsiella, your Acinetobacter, your E. coli, which are playing havoc in most of our hospitalized patients and also now community. Utilize PKPD principles. We will hear a lot more of this in our subsequent lecture. But remember that we must take into account pharmacokinetics and pharmacodynamics and think of the PKPD characteristics of antibiotics, whether they are time dependent or concentration dependent. So we need to give infusion for time dependent. We need to give high dose once a day for concentration dependent and optimize these drugs to the maximum. So we will hear more about this in a subsequent lecture. What about the duration of therapy? It is a dilemma. Longer than necessary duration predisposes to increase in toxicity and adverse effects, emergence of resistance, increase in duration of hospitalization, and non-compliance. So, how do we optimize it? We need to have some biomarker maybe and look at the clinical response. So, we use a host of different things. You can't just say, I'm going to base it only on one thing. Today, the role of procalcitonin seems to be promising, but don't think only procalcitonin will help you. You need to follow a few other things. Patient is improving, fever has settled down, his counts are settling, his appetite is improving. If you are already on some, systemic support like ventilation or something, all those are coming down, then you need to think that this is the time to take away my antibiotics. So, this is a rough guide. Okay, again going back to the re-evaluation by the WHO, it has to be an informed re-evaluation. So review your microbiology data, assess the spectrum of the drug you were giving. Suppose you got, say, a UTI, you got an E. coli, which is very sensitive to any of your simple drugs. You don't need to continue your broad spectrum third generation cephalosporin. You can narrow down to a much simpler antibiotic, maybe a nitrofurantoin or something like that. See whether you have been, whatever drug you're giving has adverse effects. Evaluate the route and duration of therapy. And this is another chart, looks very scary, but not at all scary. So suppose you suspect serious infection, this is for a patient maybe in the ICU. Always obtain appropriate cultures, then start empiric antibiotics based on your local antibiogram. Consider sending a biomarker like CRP or a procalcitonin at this time. 48 to 72 hours later, you need to reassess the patient. Is there clinical improvement? At the same time, pursue aggressive source control. Now, suppose you have a patient with a burst abdomen, a perforation. You don't operate that patient, you're not going to get any source control. You're not going to get any clinical benefit. You may think I'm doing everything, but why is the patient not improving? So maybe that patient needed an abdominal imaging, right? So if there is clinical improvement, then you look at whether cultures are negative. You have made an alternative diagnosis. You can stop antibiotics. You need to be bold at times to stop antibiotics. Cultures are negative, but still you suspect infection because something else prompted you to think that there was an infection. De-escalate and treat for the shortest duration possible. Cultures are positive, again de-escalate based on your culture. There is no improvement, cultures are positive. Maybe you need to optimize antibiotics. Maybe you need to consider complications or other diagnoses or pathogens. You may consider repeating a procalcitonin. If it has fallen from there to there, you know you were doing the right thing. But that doesn't mean that I started with 4 antibiotics. Just because I got improvement with that, I got a culture positive which tells me to stop 3 and continue with only 1. You should not say, I got improvement with these, I don't know which helped him, I'm going to continue all 4. That is not going to be rational. So, There is no one rule that fits all clinical situations. We know that every patient behaves differently. But we should at least try to stop and think at the end of 3 to 4 days. That is the treat for 7 days. Consider local guidelines. This was an effort by the government by coming up with some national antimicrobial treatment guidelines in infectious diseases. For critically ill patients, ISC hospital antibiotic policy, nothing like it. That is the best, because that way you know your local bugs and you would be treating. But remember, an antibiotic policy cannot be isolated for one area in the whole hospital, because you will get patients from other wards, you will get patients from outside. You have to have a uniform policy across the hospital. So here I would say, review the principles of antibiotic prescribing. Microbiology guides therapy wherever possible. Your indications should be evidence-based. You should use the narrowest spectrum possible. Dosage should be appropriate to the site and type of infection. Minimize the duration of therapy and ensure monotherapy in most cases. Right? With that, I had a chance to come upon this, published a year ago in January 2019, Rethinking How Antibiotics Are Prescribed, incorporating the 4 moments of antibiotic decision making. So just like we have hand hygiene, my 5 moments of hand hygiene, this is published in JAMA last year. These are the 4 moments of antibiotic decision making. So the first is, does this patient have an infection that requires antibiotic? Here they give the example of a 34-year-old with fever, dysuria, hypotension, flank pain. Patient has signs and symptoms for pyelonephritis. Pyelonephritis is a serious infection. You cannot not treat this patient. So you start something. Maybe you start an intravenous 3rd generation cephalosporin perhaps. Have I ordered appropriate cultures before starting antibiotics? What empirical antibiotic? Urine dipstick indicates pyuria and bacteriuria. Blood cultures and urine cultures are obtained prior to administering antibiotics. Ceftriaxone is prescribed. Broader therapy is not indicated because the patient has no risk factors. So I said about risk stratification, not a diabetic. He's only 34 years old. He's previously healthy. Staph aureus and vancomycin, no. Those are not common organisms for pyelonephritis. 2 days have passed. Can I now stop antibiotics, or can I narrow the spectrum? Can I change from IV to oral? Why does IV to oral help? Because you will simply discharge the patient. So once the patient is out of the hospital, at least your hospital is not going to have the other effects like the resistant bugs going and colonizing him because he's already on an antibiotic. Patient has an appropriate response. Urine cultures prove E. coli, resistant to trimethoprim but susceptible to Cipro. So perhaps I could change over to Cipro and send the patient home. He switched from oral IV to oral. Now I need to think about the duration of antibiotics. Patient is on day 3 of therapy and ready to be discharged. Treatment with Cipro for 7 days has been shown to be effective for pyelonephritis. The patient is discharged home to complete additional 4 days of antibiotic therapy. So that is the way, and that is the best summary that I can give of appropriate antibiotic therapy, because this has incorporated most of the principles that I have talked about. How you need to send a culture before you start something. Always review at the end of 3 to 4 days and think seriously about the duration and have a diagnosis or a possible diagnosis at the end of 24 to 48 hours. With that, I will stop and would be happy to take your questions. Thank you.